All right, I'm going to go ahead and get started. So, welcome to the Department of Medicine Grand Rounds, everyone here at the University of Wisconsin. It's a beautiful Friday morning here, and I am Dr. Betsy Trowbridge, and I am the Executive Vice Chair for the Department of Medicine, who is standing in for our Chair, Lynn Schnapp, today. And I am very excited about our Grand Rounds, which is a panel today, which is entitled Health Policy and Hospital Medicine 2020 is a Catalyst for Change. And I think there's really been a theme on our Grand Rounds in this past year, which is, taking what's happened during this time in 2020 and looking at it as a way to move forward and change where we're at. And so our panelists today are Dr. Ann Sheehy, MD, MS, who is the Chief of Hospital Medicine, the physician assistant, Paula Sinkar. I had to have her teach me how to say her last name just before this. Dr. Jesse Maupin, Dr. David Sturkin, and Dr. Brian Williams. They will each be introducing each other, and I will introduce Dr. Sheehy. So as many of you know, Dr. Sheehy is here at University of Wisconsin. She did her medical degree at Mayo Clinic, where she also did a master's in clinical research, her residency at Johns Hopkins in internal medicine, and is currently division chief. And since we have a large panel, I'm just going to do a couple quick updates. Ann has received numerous awards. Most recently, this past week, she received the coveted UW Health Leadership Award. In 2015, she received the Society of Hospital Medicine National Award for Outstanding Service in Hospital Medicine. I think a lot related to the policy work they're going to talk about today. And in 2014, she was the ACP Top 10 Hospitalist Awardee. She has over 52 publications. She has done over 11 national invited research presentations, and she is highly involved in public policy and legislative action, really on behalf of the patients that she takes care of and that we take care of, and hospital medicine, very most recently with the observation status in the 3 Midnight Rule. What you might not know about Ann is she is a big athlete. As part of that, she serves on the UW Athletic Board, which is a great honor. So with that, Ann, I'm going to go ahead and let you get started.
Thank you for that kind introduction, Betsy. And I will go ahead and get started, and you can go to the next slide. We have no disclosures. So our objectives today is we hope that participants will understand how to participate in health policy advocacy in compliance with SMPH and UW Health rules. And we hope that participants will understand that providers can advocate as private citizens, as members of professional organizations or societies, or as representatives of UW Health. So our outline will be as follows. I will give an overview of health policy and talk a little bit about policy in the workplace and an advocacy survey we conducted here in 2018. And then I'll shift the talk to our 4 other co-presenters who will give examples of work in hospital medicine. So the year 2020, so I think we can all relate to 2020 depicted exactly like this. This has been a hard year with COVID, political and social unrest, just to name a few things we've all experienced this year. You can go to the next slide. So how do we react? So there's lots of ways to cope with this. And I would say that humor is one coping mechanism, and memes have been raging in the year 2020. And I especially love this Steve Carroll meme where the time traveler lands, unfortunately, in 2020. And I think his face says it all. You can go to the next slide. So how do we react? So we can flip through endless memes to make us feel better. And coping, that's a healthy coping mechanism. But we would suggest another way, and that is to take a look at the things that have really made us angry, frustrated, sad, and sometimes made us feel hopeless, and turn that into an opportunity for change. And really, this is the reason we're giving Grand Rounds today, because we feel that this year, the year 2020, has presented so much opportunity for advocacy, specifically in the area of health policy. Obviously, the open letter signed by so many of you a couple weeks ago is exactly the sort of effort we are talking about, because advocacy can take many forms. Next slide. So advocacy in hospital medicine, it just happens that many hospitalists in our group are heavily involved in advocacy in a variety of ways. And we don't claim to be world experts, but we hope that by sharing our ideas and experiences, others might be able to take the first step in an area they care about. And this is something I'm very proud of in our group. As a side, I'm taking the opportunity to use this grand rounds to say thank you to my team. That is the team of hospitalists. You really learn the true colors of individuals and groups when they are put to a tough test like we have experienced this year with COVID. And I will just say that this group has continued to step up beyond anything I could have hoped for. And so in the context of team, we thought that a team-based grand rounds was most fitting for the times. Besides advocacy, we will even demonstrate some unique hospital medicine skills like handoffs. And if I can brag a little bit more about our team, we also pride ourselves in innovation. So we are using this grounds to bring forward what we think is the first APP to give Department of Medicine grand rounds. You can move to the next slide. So what does UW-Madison or SMPH say about advocacy? So this summary I vetted with government affairs and they approved this definition. And it says a general rule of thumb is advocacy activities must be done separately from work time or work locations, and employees must use only personal resources unless authorized by the university. Next slide. UW Health's definition is very similar. UW Health's employees are expected to use their own time and resources when engaging in political activity if their job at UW Health does not specifically involve such political advocacy. So really both statements are very clear that you need to do advocacy work with your own resources on your own time if you're not acting as an agent of UW Health or SMPH. I would also add that providers should not use their affiliation with SMPH or UW Health unless authorized to do so. However, this leaves open a lot of room for provider advocacy. This is what we're going to talk about today. We will provide examples of advocacy on behalf of UW Health. We will also talk about advocacy on behalf of a professional society or organization, and we will talk about advocacy as a citizen advocate, where citing your medical degree but not place of employment is appropriate to demonstrate medical expertise on an issue of importance. So again, what is the current landscape of physician engagement? Well, this was a study published in the Journal of General Internal Medicine in 2007, and this was the current population survey November voter supplement. And this was sent in all the midterm elections and general elections during that time period. And there were 350,000 participants in this article that was just simply titled "Do Doctors Vote?" And about 1,300 physicians were included, as well as 1,900 lawyers. And I think lawyers were included in this study population as sort of a control group for a professional, another professional group. And unfortunately, the answer to "Do Doctors Vote?" is no. The odds ratio for physicians voting in a general versus the general population was 0.70. So what that means is physicians voted at a rate at about 30% less than the general population. Lawyers voted at a rate higher than the general population and obviously at a rate higher than physicians in all four of these elections. So since we've just been outdone by lawyers, I think it's appropriate to tell a lawyer joke. And this is a physician asking his patient, "Where does it hurt?" And the attorney answers, "My client does not wish to disclose that information at this time." You can go to the next slide. So what's the current landscape at UW Health? Well, we conducted a survey of physicians in fall of 2018, and we mailed the survey in October and then sent 3 follow-up emails and closed the response period in January of 2019. So this did straddle the 2018 midterm elections, so perhaps a more engaged respondent pool. And there were 28 survey items to determine physician engagement, barriers and benefits to advocacy, and training received. And a priori, we established a definition of a highly engaged physician. They either had to participate in a high effort activity, they self-reported monthly or weekly policy involvement, which we termed high involvement, or they had 10% or more work time dedicated to health policy, which we called high work time. Next slide. And so we had a high response rate. About 62% of physicians responded to our survey. The respondents were largely male, white, under age 65, of non-surgical specialties, and about 55% were Democrats, 24% independent, and 7% Republicans. Go to the next slide. And so basically 15% of our respondents, or 133 unique respondents, met our definition of highly engaged. 91 met 1 criteria, 32 met 2 criteria, and 10, the center of that Venn diagram there, met all 3 criteria. But there was a lot of other advocacy going on of people that didn't quite meet our definition. For example, about 24% were actively involved in professional societies, 9% used mass media or public events to promote health policy advocacy, and 35.6% contacted legislators. Go to the next slide. So barriers and benefits were really important to find out why were people getting engaged in policy. So those highly engaged and those less engaged most commonly cited improving a situation or issue or improving the health of the public as reasons to get involved. Not surprisingly, the main barrier was lack of time for both groups. I will say I was really impressed to see that very few people thought that health policy was not important. So 0.8% of our highly engaged group and 2% of our less engaged group. There was a significant difference between those who said, I don't know how to get involved, between our highly engaged and less engaged groups. So 34.5% of our less engaged population did not know how to get involved, which again is one of the reasons we're giving grand rounds today, to give some ideas of how people can get involved. And then at the bottom, 7 to 10% of people said they couldn't be involved in advocacy due to employment. And again, another reason why we're giving this talk today is to give people information how they can get involved in policy as UW Health and SMPH employees. Next slide. So training was also very important. So less than half of our employees and respondents had any sort of training in health policy and advocacy, 48.9% in our highly engaged group and only 18% in the less engaged group. And I will say that very few in engaged or less engaged group had formal med school or college training. The most common way people obtained training was at sessions at conferences. So I see this as a good and a bad. This may argue for more formal curriculum in med school and undergraduate levels. On the other hand, sessions at conferences and professional meetings are accessible to everyone at all levels of experience. So maybe that's actually a positive. And you can go to the next slide. So just to summarize, I think UW Health physicians find policy to be important, but there is a group that does not know how to get involved, which again is a reason why we're giving this talk today. And then some people feel they can't be involved in health policy and advocacy due to employment, which is again another reason we're giving this talk today. And so now we're going to shift to providing 4 examples from our division on how to get involved in health policy. And you go to the next slide. And as promised, we're going to demonstrate handoffs. This is the hospital medicine warm handoff. And I'm going to introduce Brian Williams, who I'm handing off to. Brian earned his undergraduate and medical degree here at UW and joined our hospital medicine group in 2018 after spending time at UC San Diego, where he completed his MedPeds residency. He currently splits his duties as a MedPeds hospitalist and spends 20% of his time working in tobacco research at UW C-Tree. Take it away, Brian.
Great. Thank you very much, Anne. And I am absolutely thrilled to be talking today about advocacy. Advocacy gives us an opportunity to impact change on a level that's a little different than we do with providing patient care. And it's also something that can be incredibly rewarding. As we think about advocacy, I think it can sometimes be overwhelming, because if you look at some of the challenges that our society, our community, our medical field faces, there's a lot. And I would encourage you to really go after what you're passionate about. If you're advocating something with a sense of passion, it can help you get through some of the tough times when you may not be making progress as quickly as you'd like. For me, I got irked in residency when I was taking care of kids, bronchiolitis, recurrent asthma exacerbations, and you'd walk in the room and it would smell like an ashtray. And I felt really bad for the kids. I felt really bad for the parents. And sure, we'd try and provide some counseling for parents, but it never felt like enough. So my advocacy started as really quality improvement work in the hospital, trying to systematically screen for tobacco smoke exposure, and then have a formalized education curriculum that we would provide for the parents, and then an automated referral to the state tobacco quit line. So that was a small win. And the other thing that gave me passion with in the tobacco field is the populations that are really burdened with tobacco dependence, nicotine dependence, are a lot of highly disadvantaged populations. So there is a social justice issue in tobacco. We know some of these populations have also been targeted by big tobacco. So that also drives some of my passion. Now, a couple of years ago, my advocacy focus changed a little bit as a result of the rising adolescent vaping epidemic. You can see between 2017 and 2018, high school vaping rates nearly doubled. So about 1 in 5 high schoolers reported vaping in 2018. And this got a lot of national attention. It got the FDA's attention. They started investigating Juul, the #1 seller of e-cigarettes. And they also started doing a lot of online sales verification and even brick and mortar raids to make sure that people weren't selling to youth. Amazingly, the rates continued to climb, and in the fall of 2019, the National Youth Tobacco Survey rates were up to 27.5%. So over 1 in 4 high school students self-reported using e-cigarettes. So this was quite a concerning time. And as you can see, if you look at the cigarettes bar graph, rates of cigarette use have been declining. They've been declining in adults and they've been declining in adolescents for the past couple decades. So this youth vaping epidemic really threatened to wipe out all that progress. So I sort of got annoyed and started writing some op-eds. 2 big things that I thought could make a difference in the youth vaping epidemic were, one, raising the tobacco age to 21. And this was not a unique idea. About a dozen states by 2018 had already raised their state's tobacco age to 21. But I did think it would be an opportunity for Wisconsin to hopefully help curb youth vaping. The other huge thing that I think could really help, keep kids away from e-cigarettes is to cut flavors from e-cigarettes. The Department of Health Services in Wisconsin did a survey in 2018 that showed that 89% of high schoolers reported they would not use flavored e-cigarettes. So that has also gotten some attention nationally, and several states have passed various forms of flavor bans. And actually, in January, the Trump administration enacted a vaping flavor ban. Now, this ban was influenced by industry and had a couple huge loopholes. One, if you were using a refillable e-cigarette, the flavor ban did not apply there. And they also exempted a category called disposable e-cigarettes. Now, at the time, no one was really using disposable e-cigarettes. But since this flavor ban took place, all the major e-cigarette makers have started making their own disposable e-cigarettes. So it tells me that industry had a lot in crafting that language. So I got more annoyed and wrote another op-ed saying we really need a comprehensive flavor ban that eliminates these loopholes and really helps keep these devices out of kids' hands. Now, if we go back a year, which feels like 5 or 10 years ago, in the fall of 2019, on top of the rising youth vaping rates, we also had this mysterious lung disease. And people did not know what was causing it, and it was killing otherwise healthy young adults. So this also got a lot of media attention. And if you think back to September, we had this new report of over a quarter of high schoolers using e-cigarettes. On top of this disease, this really presented an opportunity for advocacy. At AFCH here, we had a case of EVALI, which is the term for the lung disease, and working with Vivek Balasubramaniam, the pediatric pulmonologist that was caring for this child, Logan, in the pediatric ICU, we had the idea of putting together a press conference to try and help inform the local public. Logan worked with our media department and actually came up with a statement that was incredibly powerful, sort of telling his story and really encouraging his peers not to use e-cigarettes. And this got run by all the local media stations. And then that night, Nora O'Donnell with the CBS Evening News opened her broadcast with Logan speaking, and that was a really powerful moment and a great win for advocacy. Now, informing the public, I think certainly is incredibly important and can have a huge impact. But the other piece that can have a huge impact is really enacting legislation. So Tobacco 21 did gain more and more steam. And a bill was introduced last fall, I think as a result of both the vaping epidemic and the EVALI outbreak. And again, we had the opportunity to work with UW Health and SMPH to testify at both the Assembly and Senate hearing committee meetings. And, going into this, I was sort of intimidated, a little overwhelmed, thinking I shouldn't be talking. You go into this beautiful marble room, it's a little intimidating. But you quickly realize these legislators are dealing with a huge breadth of topics every single day. And as medical providers, we can really engage in meaningful conversation with them and hopefully educate them on the reality of vaping. And we tried to do that by really targeting how much more addicting nicotine was for adolescents. And also that there's not only individual benefits from raising the tobacco age to 21, but also some major societal benefits. And this was fortunately passed in both the Senate and Assembly committees. So I'll close there by just encouraging you to find your passion when you're thinking about advocacy. Use your expertise. We're very fortunate as medical providers to hold a certain standing in society. And oftentimes when we speak, people are willing to really listen to what we have to hear. I'd encourage you to start small with op-eds, maybe even calling your local reps. Those are things that can usually just take a few minutes. And then build off your success, try to work with others, build coalition. And then when you have big, powerful groups of voices, that is an opportunity to really enact change. And I will turn it over to Paula now. So Paula Sinkar is a graduate of UW-Madison and currently a physician's assistant in hospital medicine. She originally joined UW Hospital in 2002 with the Abdominal Transplant and Surgery Medicine Group and transitioned to the Division of Hospital Medicine in 2015, where she currently serves as the APP supervisor. Take it away, Paula.
Thank you, Brian, for that introduction. I appreciate being able to talk with all of you about my work on advocating for my profession. At UW Health, we use the acronym APP, which means Advanced Practice Provider. This title covers nurse practitioners, physician assistants, and midwives. UW Health currently employs approximately 560 APPs. In Wisconsin, there are about 2,600 PAs and 4,500 nurse practitioners. When I started my career at UW in 2002, there were about 85 APPs and only a few that worked in the inpatient setting. In my time of practice, I've encountered barriers that limit what I'm able to do with the training and education that I have earned. I relied on others in my profession to spend the time and effort in advocating for my occupation by working to educate lawmakers to help make Wisconsin laws better reflect our education and training. I decided that I should start participating, so I became actively involved with WAPA, which is the Wisconsin Academy of PAs, by attending meetings and conferences. Next slide. This organization advocates for PAs in our state and also puts together professional activities such as PA Day at the Capitol, where PAs meet with legislators and discuss issues regarding our profession. We would meet with lawmakers at the state capitol and talk about the impact we have on patient care. Next slide. In early 2020, WAPA asked me to testify for a bill that had already passed the Assembly and was now up for public hearing in the Senate Committee on Health and Human Services. This bill, Senate Bill 254, would allow APPs to legally determine capacity as well as sign out of hospital DNR forms. They asked me, since I work in hospital medicine and the determining whether a patient has capacity is a daily occurrence in my profession. Why is this bill important? This streamlines patient care and allows patients' primary care providers to be involved in these services. APPs often serve as the principal healthcare professional for patients. Next slide. The main purpose of my testimony was to inform legislators about what a PA is and the education that we receive, and how this education and training qualifies us to make these medical decisions. I testified alongside the Wisconsin Hospital Association, who also supported this bill. Next slide. Ultimately, this bill was passed and becomes a law on February 5th of 2020. I was fortunate to be able to attend the bill signing. Again, this law allows NP and PA signatures as a second signature on certification of incapacity. It also allows NPs, PAs to sign out-of-hospital DNR orders. Recently, UW Health updated its policy to reflect this new Wisconsin law. Next slide. I realize that APPs need to advocate for our profession. I used to rely on others to do this, and this responsibility cannot fall on just a few. If we want to make change, we all need to make time for this. So how do you get involved? Be aware of current practice laws and local regulations. Alert your health system and state advocacy groups to any practice barriers. I invite you to look into your state associations. For PAs, there's the Wisconsin Academy of PAs, and for nurse practitioners, it's the Wisconsin Nurses Association. Work with your health system to identify and eliminate barriers to care. And then make sure to work within the policies established by your employer. No one else knows what we are capable of doing better than we do. We should all be working at the top of our license, and we all should spend time working to advocate the APP profession in Wisconsin. With that, I would like to introduce Jesse Mopan. He received his medical degree from the University of Washington before moving to Madison, where he completed internal medicine residency on the primary care track at UW. He joined the Division of Hospital Medicine in 2018. Take it away, Jesse.
Great, Paula, thank you so much. It's really an honor to be here to co-present Grand Rounds with you all. So today I'd like to talk about some ways that as medical providers we can advocate for diversity, equity, and inclusion within the field of medicine. So in the next several minutes, I'll go over how I became interested in this topic, why I feel like this is critically important to our clinical practice, some of the activity within the Division of Hospital Medicine, and then parallel efforts at UW Health and SMPH more broadly. Next slide, please. So first, I think definitions are key, and I think having a universally agreed upon definition is important. So I really like this definition of structural racism, which is really at the root of a lot of what I'll be talking about. This definition comes from some researchers out of Berkeley, California. So structural racism can be defined as the normalization and legitimization of an array of dynamics, both all historical, cultural, institutional, and interpersonal, that routinely advantage white people while producing cumulative and chronic adverse outcomes for people of color. This is a system of hierarchy and inequity primarily characterized by white supremacy. The preferential treatment, privilege, and power for white people at the expense of Black, Latino, Asian, Pacific Islander, Native American, Arab, and other racially oppressed people. Next slide, please. So as I believe many of our department members in the Department of Medicine, I grew up in predominantly white spaces. I always kind of privately had sort of passive anti-racist beliefs. I was never really required to acknowledge my own racial identity or the privilege that comes along with that. So whiteness was always sort of the default setting throughout much of my life. Over this past summer, after the killings of George Floyd and Ahmaud Arbery and other high-profile cases, I was really kind of hyper-focused to the national discussions around racism, historical and contemporary, and I was really kind of wanted to learn more and engage on the subjects. So in July, during the course of a normal workday for myself, I admitted an elderly Black woman from the emergency department to the inpatient setting for pneumonia. And as we were wrapping up our conversation, I asked this patient of mine, what are some important things I should know about her in order to take care of her better? And she really opened up to me. I'm not sure what prompted her to share this with me, but I'll just sort of paraphrase what she said to me here. She said, "Doctor, there are people in my neighborhood that don't like me because I'm Black. Racist people have been treating me badly for most of my life, and I'm so sick and tired of it. Most days I just want to scream. If I get the feeling that somebody's treating me differently because I'm Black, I'm going to leave this hospital. I don't care if I die at home." So it struck me that if I hadn't really elicited this statement from my patient, I really wouldn't be seeing the full person in front of me, and I'd be failing in my duty as a physician to provide comprehensive, holistic care. So this prompted me to really want to examine some of the racial disparities in the state of Wisconsin a little bit more closely. Next slide. So I'm sure many of you have seen similar statistics. I just want to highlight a few very shocking and frankly embarrassing statistics from our state. So in Wisconsin, Black infant mortality is greater than 3 times that for white infants, 14 versus 4.7 deaths per 1,000 births in our state from between 2013 and 2015. Next slide. Black life expectancy, similar for adults, is about 6 years greater for white adults versus Black adults. So starting at birth all the way through the life continuum, we see significant disparities in morbidity and mortality. Next slide. And then more recently in 2020, which is COVID-19 is on everybody's minds, the share of deaths from COVID-19 among our Black Wisconsinites is just disproportionately higher. So Black Wisconsinites make up about 6% of our state's population, but as of September of this year, they accounted for about 26% of deaths statewide. So just really kind of shameful numbers, and I don't have the explanations for why this is the case in this presentation, but I think it's worth kind of considering these facts. Wisconsin is second only to the state of Kansas in this disproportionate share of deaths. Thank you. Next slide. So, you know, I think it's really important to acknowledge that there's a lot of mistrust of the medical community, the medical establishments in African American as well as other minority populations. And I think there's a lot of evidence that this mistrust is justified. So, you know, research exploiting African Americans was really the norm for much of our nation's history. Black patients were commonly regarded as fit subjects for non-consensual, non-therapeutic research. So what are the consequences of centuries of abuse? And I'll just put a quick plug in here for this book by Harriet Washington, which really examines in detail a lot of the history of medical abuse in this country. Next slide, please. So, you know, this mistrust doesn't just go away in our modern era. A Pew Research Center from September of this year surveyed about 10,000 Americans, adults, about their trust in the medical establishment, and more specifically in the COVID-19 vaccine that we now have on the horizon. In the red box on the right side of the slide there, you'll see that mistrust is generally fairly high among Americans, but among Black Americans, there's only about 32% of adults in this survey who said that they are open to receiving the COVID-19 vaccine. I found that appalling and sad, given that this population is disproportionately affected by this disease. So this mistrust has consequences and real life impacts that follow us into the office, into the hospital setting, whenever we interact with these patients. So if we're really not understanding the roots of this mistrust and how it might impact their acceptance of our recommendations, we're really failing them as providers. Next slide, please. So I was introduced to some individuals from the DEI committee in the Department of Family Medicine and Community Health earlier this summer, and I learned that several of them had put together this training series in 2018, consisting of 30 modules spanning topics aimed at educating not only medical providers but other staff within UW Health more broadly on topics including racial health disparities in Dane County, history of racism in healthcare, and concepts such as intersectionality and implicit bias. I was really intrigued by this curriculum. I'd never heard of it before, and I got permission to adapt some of the resources to be delivered to our division of hospital medicine in the form of monthly emails. You know, this really wasn't a time for us to gather in large groups. So most of the materials for these modules consist of publicly available YouTube videos, articles, and worksheets designed by the Department of Family Medicine DEI committee. So I've been sending out these information from these modules on a monthly basis since the summer, and we're encouraging discussion within our division through monthly division meetings and via secure group texting apps. And this really came from a place of recognizing that talking about racism and similar topics is often considered impolite and rude, especially in the professional setting. And I really felt like it was time for myself to put myself into some of these uncomfortable situations and try and bring some of my colleagues along with me, because clearly we need to be talking about these things more. Next slide, please. So along with this, we conducted a survey of our division about these topics and sort of what people's comfort levels and level of engagement was in talking about these issues within the professional setting. So we put together a 9-question survey, which we sent out to our division. We had about a 33% response rate within our division. And I just want to highlight two very striking findings that we came across. So about 86% of our division really desired employer-led education around racism and health inequities. People really want to talk about these topics, and they feel that their employer is an appropriate entity to bring these topics forward. The next question we asked was, how confident are you in your ability to address discrimination in the workplace, either coming from patients, from other staff, any discrimination that you might see in the workplace? And none of us were very confident in our ability to address discrimination. The majority of people were somewhat confident, but there was a lot of discomfort around confronting these issues in the workplace. So I saw a huge disparity there. People want to engage and to learn, but we don't feel like we have the tools to really put these lessons into practice. Overall, there was a strong desire for more community engagement with underserved groups, and really our providers wanted UW Health to be a leader and give us opportunities to engage with the community and use our skills for good. So the results of this survey were written up and submitted as a brief report to the Wisconsin Medical Journal, currently under review for publication. Next slide, please. So what is UW Health and the School of Medicine and Public Health doing more broadly? I'm really proud to be at UW Health and a faculty in the SMPH. I feel like there's a lot of great work going on that I just want to highlight. First off, the Bias Reduction in Internal Medicine initiative was launched in, I believe, 2017 and 2018, rather. This has been implemented at 19 institutions nationwide, and our division participated in February of 2019 here, led by Dr. Molly Carnes and others. In the division of nephrology, Dr. Jamali has recently recommended that we eliminate our race-based adjustments in calculating estimated GFR, replacing those with cystatin C formulas. And this is really an acknowledgement that race is a social construct, not a biological one. In October of this year, UW Health joined the other local health systems in a joint editorial proclaiming racism as a public health crisis, really putting this forward into the press to make our position known. And there are internal UW policies recently adopted protecting staff and trainees from discriminatory behavior. There's ongoing recruitment of a chief diversity and inclusion officer at SMPH, really recognizing that this needs to be a full-time executive position, which I admire. And the Department of Medicine recently convened the DEI committee to give recommendations for diversifying faculty and trainee recruitment, improving the workplace environment, and nurturing underrepresented faculty development. Just last month, there was the UW-Madison Diversity Forum hosted campus-wide, which hopefully some of us were able to participate in. And we're currently conducting ongoing research about discrimination and health disparities in our state, advocating for change really across the campus, because I think we all know that we can be doing better. So with that, I'm going to hand this off to Dr. David Sturken. David Sturken earned his Bachelor's of Science in Biochemistry from UW-Madison before going to University of Pennsylvania to earn his doctorate in medicine. He then completed internal medicine residency at Duke University, followed by an academic hospital medicine fellowship at University of California, San Francisco. He joined our division of hospital medicine in 2019. Thank you, David. Take it away.
Thanks, Jesse. So my section of this talk is going to be on engaging in local government advocacy as a healthcare worker. Next slide. And I'd actually like to start my section by undercutting my own credibility on this topic a bit, because I'm not an expert at this. I'm not putting nearly the amount of time and effort that others have, including some others at our own institution who are experts. So I'm not really here to give you a master class on being an effective advocate or activist. And I'm also not really here to convince you that doing so is important, because I think everyone on this talk already understands that to be true. Next slide. The reason I'm giving this presentation is because people like me, people with multiple layers of privilege, are simply not doing enough. And as one of those people who has not done enough in the past and is still not doing enough now, but is doing a little bit more than I was before, I hope that by giving you some examples today of how I personally got over the activation energy to get started, that hopefully that can make it easier for others to get started as well. Next slide. And for me, my engagement has mostly consisted of advocating for or against local government initiatives at the sort of Madison level. One of the most impactful recent initiatives was the creation of the Office of the Independent Monitor and the Police Civilian Oversight Board, which was led in part by Alder Shiva Badar, who was one of the 3 alders on the work group that created it, and who, by the way, in addition to being a city alder, also works at UW Health. More recently, there was a ban on the use of facial recognition software in law enforcement, which was passed by the City Council. And then my most directly medically related initiative that was non-COVID related, at least, was for a proposed ban on the use of tear gas, one of the versions of which was also written in part by Alder Shiva Badar. Next slide. But for starters, I want to address some of the barriers to getting involved, because if we agree it's important for but people like me are still not doing it, then we need to talk about why. Now, I can only speak for myself on this, but I think that some of these barriers likely apply to others in situations similar to my own. And number 1 and 2 on this list are a lack of personal connection and a lack of time. For me, my privilege insulates me from the effects of most public policies, which can lead to a sense of a lack of a personal connection and result in feeling like advocating is optional. It'll be relatively easy for me or someone like me to ignore public policies and ignore the structural inequities built into society, and then to just go on living our lives without thinking about these issues, let alone doing anything about them to change them. And this lack of personal connection is compounded by a lack of time, or at least a perceived lack of time, because at least for me, when I feel busy, I tend not to do things that I consider to be optional. I don't really have any great advice for getting over this other than to emphasize that it really is just a perception issue. It's important to have the perspective that for others that don't have the same kinds of privilege, they feel the effects of public policies every day. So they can't ignore these issues just because they don't feel like they have the free time or feel too busy. This is not optional for them. So people like me shouldn't consider it to be optional either, because even if you didn't create the structural inequities that lead to your privilege, you still passively benefit from them and you perpetuate them through your inaction. So you have a responsibility to promote change. Next slide, please. Another barrier is that we may feel that our institution or even our patients might expect us to remain apolitical. This is fairly easy to deal with, however. Before making a statement, you can give a disclaimer saying that your views are your own and don't necessarily represent those of your employer. You can use your credentials like saying you're an MD without listing your affiliation, which means not listing that you work at UW. And of course, you should always use things like your personal email, do this activity on your personal time, etc. Next slide. And some other barriers could include a sense of futility, concerns that you don't know enough about the subject to advocate, or simply not knowing how to make your opinion heard. Next slide. But overall, I think one of the best solutions to many of the barriers that I just listed is to advocate on the local level. I won't go through these points in detail, but suffice it to say that there are good reasons to think globally but act locally. I would also like to specifically point out that now that these meetings are all virtual, that actually makes it much easier to attend them since you can do so from home. Next slide. So I just want to go through a few small ways to get started, specifically focusing on local Madison government, since that's what I'm most familiar with. Some basic steps are, first, find out when your topic of interest is going to be discussed, or look through all the topics being discussed and then determine what you're interested in. Then do some background reading, share what you've learned with others, register for meetings and send emails to officials, either attend the meetings live or watch them later. And then also it can be helpful to seek out other individuals and join interest groups in order to help keep yourself appraised of important upcoming meetings and also to share information. Next slide. So in Madison, there are a few different ways to do that, and many different web pages. Some are kind of redundant, but one that I like is this one here with the URL at the top. This one has the upcoming meetings and hyperlinks to each of the virtual pages. Next slide. So for example, this is a page for a virtual meeting, and you'll see the thing that I have circled in it first is the agenda. Next slide. So if you click on that, it'll take you to a PDF of the agenda. The red circle on the left is the agenda item number, and then the circle right next to that is the ordinance number or resolution number, which also has a hyperlink that takes you to the actual text of the ordinance or resolution. Next slide. And then if you go back to the virtual meeting page, you can see in order to make your voice heard, one, they give you an email address that goes to the members of the committee. When you're sending that email, you should include the agenda item and also the ordinance or resolution number. And then below that, there's a button for registering for public comments. And next slide. So if you click on that, the first two things to do when you register, first, you list the agenda item. That's the first circle. Then you indicate if you're supporting, opposing, or neither supporting nor opposing. And you also indicate whether you want to speak. If you say you want to speak, they'll send you a Zoom link to your email. If you say you don't want to speak, they won't send you a Zoom link, but you can still stream it live on the webpage. And if you say you don't want to speak but are available to answer questions, you'll still have a Zoom link, but you won't get called on unless somebody asks you a question. And when you do get to speak, you generally get a strict 3-minute time limit. Next slide. Below that, you indicate if you're representing any organizations or lobbying in some capacity. Obviously, generally, you click no on that, and certainly shouldn't indicate that you represent UW unless you were specifically told to do so. And below that, you have to give your contact information. They need your full name in order to connect that to your registration with your Zoom registration. They need your email to send you the Zoom link, and they need your phone just in case the connection is poor and they can't hear you, so they need to call you. Then lastly, they do ask for your address, but during the meeting, they'll only say your street name or the city that you're coming from if it's not Madison. So they won't disclose your whole address publicly. Next slide. Going back to the virtual meeting page, there are 2 different buttons that say watch online, which I'm pretty sure go to the same place. Next slide. So those take you to the Madison City channel page, which has a compilation of all the videos of different meetings that are categorized by the meeting type. Here you can watch recordings of old meetings, or you can stream live meetings. And if you see the thumbnails that are black are meetings that haven't happened yet or are currently happening. So you can click on those to stream live. Next slide. And then if you prefer podcasts, this webpage has them all compiled. They're also available on iTunes or any podcasting app. And the nice thing about podcasts and videos is that you can speed them up so you can listen to them faster. You can also skip to the part that you're interested in. And for podcasts, you can listen to them in the car or something like that. Next slide. And I want to just end finally with an example of where advocating as a healthcare worker went further than I thought it would. This summer, I registered as available to answer questions at a meeting where a tear gas ban was being discussed. And since I listed my name as David Sturkin, MD, I actually got called on. Now, since playing clips and WebEx can be problematic, I've just written out a quote of how I ended up getting called on. But as you can see, I was essentially called on because I indicated that I was a physician, and therefore they wanted to get my opinion. I spoke for a few minutes on this topic about some of the evidence for my position. And then after speaking at the meeting, I sent an email to the council, the mayor, the police chief, and sent a bunch of references with the data that supported my position. And then actually the medical director of the police departments responded to my email and sent that response to the Public Safety Review Committee, the police chief, and the alders. So then I responded to his response and spoke again at a subsequent meeting to address it. So I just bring up this example to emphasize that we can have impacts with our opinions and expertise. As healthcare workers, we have experience critically appraising scientific data in order to practice evidence-based medicine, and we can apply those same skills towards promoting a cogent argument for or against public policies. And in doing so, we can help promote change. So like I said, my main goal with this talk was to share some of the logistics I've learned in hopes that it will make it a little bit easier for others to get involved. And overall, thank you all very much for your time. If you have any further questions, feel free to email me. My email is just my last name at wisc.edu. And thanks again. With that, I'll hand it back to Anne.
Thank you so much, Brian, Paula, Jesse, and David. Just to summarize today, of course, always vote. Hopefully everybody voted in the November election. Advocate for issues of importance to you on non-work time as a provider, not as a representative of UW Health. Get involved in your local, state, or national society and advocate in conjunction with a society viewer position. If there's an issue you're interested in, see if there's an opportunity to collaborate with UW Health, and you can contact Government Affairs, and I've listed the contacts there. Respond if the institution does ask you if your area of expertise becomes a topic of interest that they would like an expert to advocate on. Hope you'll understand overall that work does not need to be a barrier to advocacy if these steps are followed. And again, I echo what David just concluded with. If any of us can be helpful in getting involved, please reach out to our division. We're not experts, but we would be more than happy to share our experiences with all of you. Next slide. And we'll close with a slide from another American hero who was another tragedy of 2020, Ruth Bader Ginsburg, who said, "Fight for the things that you care about, but do it in a way that will lead others to join you." Next slide. And thank you very much. We'd be happy to take questions as a panel.
And Brian and David and Jesse and Paula, that was fantastic. I think it was such an excellent example of advocating for what your passion is, but also reaching out into your kind of inner soul in an area that you might be uncomfortable with, and really working to change yourself and society with anti-racism. And I think that was just a really incredible example. So with that, one question, I'll start off with the questions, which is, what do you see the need for a curriculum for advocacy in the residency program, training our residents to have skills in this area?
Betsy, I can take that question, and I would invite the other panelists to jump in as well. I think, there is some activity going on in that space, but I think having an advocacy curriculum we would love to participate in that. And I think it's something we're all really excited and passionate about, and seeing our trainees getting involved in issues of importance to them. We'd love that. So yeah, I think I probably speak for the rest of the panelists as yes, as it would be the short answer.
Great, fantastic. And then I'm just looking, there's a question from Dr. Nizar Jarjour. What is the role of UW Health and the School of Medicine and Public Health Media and Marketing to help guide the efforts of providers?
And I can take a stab at answering that. So obviously, Nizar, thanks for that question. UW Health was incredibly helpful with the open letter. I mean, we basically, as you know, as a major part of that letter writing group, kind of worked with them, and they basically took the letter and got it published for us, and got the pages in the state journal. And so I actually think that UW Health and SMPH can be incredibly important in helping to guide these efforts. I will also say that I think that I was on a call this week with Event Strategies, which is one of our government relations group for federal issues. And I think there's a lot of resources. If there's a topic of synergy between a provider and UW Health, that they're incredibly helpful. So yes, thank you.
Are there, I know there's some things in the chat. Are there other questions in the question and answer? Because I do not see them right now.
I think we've addressed all of them. I did send a private one over to you.
Okay. And so a lot of like outstanding from Dr. Christy Bartles, Dr. Elizabeth George, such a fantastic presentation, rising awareness for your advocacy. So I think this was absolutely fantastic. I'm just going to wait one more minute to see if there are any other questions that come up.
I'll just mention, I think Dr. Belsky has said would welcome additional updates on advocacy and how to do it in the future. I wonder even if just keeping some tabs on what people in the department are doing in advocacy would be great, because I think sometimes we're all seeing, every topic, people see it from slightly different angles. And I think different perspectives are incredibly powerful in advocacy and creating a message. So maybe it's something we could work on department-wide.
What I also heard all of you saying was, Jesse and David, is like, you just have to jump in. Without a lot of, understanding you're a physician, and as a physician, we hold great power in our society, much more than we really believe that we do. And simply being willing to start somewhere at your local level, at your state level, saying yes when Connie Schultz contacts you about going up to the state legislature to testify is a great place to begin.
And I'll say Shobi points out here that SMPH has a fairly robust curriculum for medical students, which is absolutely true. So extension into GME would be great. So, and she says that AAMC is creating competencies related to these and extend these to faculty competencies. So it may be the perfect time for more of that.
Yep, excellent. Another question from Nizar. I'd like to steal shamelessly from anyone. So Shobi, whatever is available, we should use that. And I know Society of General Internal Medicine, there have been several presentations from programs, residency programs who have very robust curriculums. From Dr. Jarjour, did any of you get media training? And I know that was available at UW in the past. Is it still available for providers?
Any of the panelists want to answer that question?
I have received media training through the American Academy of Pediatrics. I'm currently the e-cigarette state champion, so part of that we had a couple lectures on media training and how to interact, which is really helpful.
And Brian, who did the media training here on site? Was it some particular person?
So I did it through the American Academy of Pediatrics.
But did you say you also did some here as well, or not, at UW? Or is it just through the American Academy of Pediatrics?
You know, I've done some media here, which is usually just a little bit of a brief back and forth with the media department, but nothing formalized. Okay.
And do you know, is there any formal training here?
I don't think there's a formal curriculum or training, although we've all kind of gotten, I think, piecemeal, training when we've been asked to do certain activities. And some of the training I've gotten has been, from our government relations group in certain circumstances. I think there's, but probably not something formal that I'm aware of. And Victoria has in the chat, very, very great point. There is an entire curriculum on equity and advocacy in the residency now. And she says if there's faculty who want to be more formally involved in that would be excellent. So that is wonderful, and that's fantastic. And maybe extending this more to the faculty level is where we need to kind of grow at this point.
I think we'll just wait to see if anything else pops up. Okay. So I do not see anything else. So I think we'll go ahead and close. And I just want to thank all of you for a really inspiring talk that gives every single one of us, whether we're very experienced or have no experience at all, a way to move forward. And I just want to thank you. And I also want to say it's also been inspiring to see how, as you do these different things, you're surveying, you're studying, you're writing quick blurbs that can be published, which I know, speaking for Lynn Schnapp, is something that we really are moving toward doing much more intensely. So great job with that. And then there is one quick comment here from Sarah Ahrens. It's important for us to model this for medical students. They have so much passion and need to see how it's done. But I think from Shobi's point of view, they may be helping us by teaching us how to do it, and we can do it with them, which would be fantastic. All right, let's see. Anne, did you see anything else?
Just Victoria's invitation. She says if there's faculty who want to be formally involved in that would be excellent. So just the plug for that's awesome. And I know she's super passionate about that work. She says reach out to her. So awesome. That's an awesome message for everybody on this Grand Rounds. So
all right. Thank you very much, everyone. Take care and enjoy the first snowstorm. Bye. Hey, Anne and group, that was really awesome. Paula, fantastic work. Your work